I was born and raised in Congo and came to Rwanda. Malaria first drew me in during my early clinical years in Kigali. I started my practicing in pediatrics wards, and as well as when I was seeing pregnant women dying from a disease that was entirely preventable and treatable. So that personal experience of watching families lose loved ones to something we knew to fight ignited my long life commitment. So what started as a clinician evolved into a conviction that strong national leadership and country-owned systems could change the trajectory of this disease across Africa. And that's why I'm still involved and still contributing to the response of malaria in Africa. You know, we already have the tools that we need. We have the evidence. We have data that is proving that it's possible. But what we need now is the political will and sustainable financing to move from control to elimination at scale. And today, team, now we must perfectly capture this moment. The science is ready, the successful country model exists, and the cost of inaction is far too high. When I joined the WHO advisory group in 2017, many still doubted whether a malaria vaccine would ever become a reality. Seeing it now protect over 10 million children every year fills me with hope. It's proof that when African countries, scientists, and global partners work together with determination, we can turn a scientific breakthrough into lives served. This is concrete proof that we can. And today we have even other vaccine. We have the R21 vaccine, which is also protecting. And I believe that there are many innovations that are coming and which I believe are really availing tools needed to end malaria. So I'm more excited by of course, the malaria vaccine, but there are the next generation dual active insecticide treated nets because they are already saving lives at scale today. What worries me most is the slow pace of regulatory approval and country readiness for tools like the gene drive mosquitoes, which I believe it's really a wonderful innovation that can save many lives. So innovation must be matched with strong community engagement, ethical oversight, and clear pathway for African countries to adopt and own this technology on their own term. And for that, we really need political will, political leadership, and also community acceptance as well, engagement and participation in deploying and rolling those innovations. So the biggest gap that I see is between global technical recommendation and country level implementable, sustainable financing. So we know what works, integrated primary healthcare delivery, strong surveillance, and domestic resource mobilization, but too often funding remains tight to short-term parallel projects instead of strengthening national system. So closing this gap requires donors and government to align beyond country-owned strategic plan rather than imposing external priorities. My message is simple and urgent. Malaria elimination is not a cost. It is an investment in Africa's future. In this time of constrained fiscal space, African governments must protect and increase domestic budgets for malaria, while international partners must move from unpredictable project funding to predictable, aligned support that strengthen country system. Now more than ever, we must treat malaria financing as a shared responsibility. So Africa-led health sovereignty, for me, it means African countries define their own priorities, finance the majority of the program domestically, and lead the design and delivery of solutions on the continent. And structurally, global health must move away from donor-driven agendas towards genuine partnership, where financing, innovation, and decision-making are co-owned by African institutions and governments. That is the only way to build a resilient and sustainable system. So what has changed is the growing recognition that diverse leadership delivers better results. We need more intentional mentorship, sponsorship, and structural changes that create really pathway for African women to lead at the highest levels.